Hello, everyone, and welcome to Mitigation Journal, the All Hazards podcast. My name is Rick Rosati, and this is your source for unique perspectives on disaster and emergency response. Today, we're talking about doing decon, some challenges for today and beyond. You know, it's interesting that with the rise of chemical instances or chemical-assisted suicides and other uses, illicit uses of chemicals, that we would consider to not protect our hospitals and healthcare systems better. Shortly after September 11th, 2001, someone gave us the idea that traditional responders would be overwhelmed and would not be able to assist hospitals in their recovery or relief efforts during a chemical or biologic event. We went on to say that you hospitals are going to be on your own, and that forced hospital systems to move into the realm of public safety. The result, of course, was an increase in salesmen and vendors. Tents, showers of every shape and size began to pop up in hospital emergency departments throughout the country. Now, this is not entirely a bad thing. Hospitals can and should have decontamination teams and equipment available to them. But the result of this situation was driven by increased dollars for funding, training, and material purchases. It might not be the case any longer. Further, the result was these hospital decontamination teams that went out and purchased additional equipment, including self-contained breathing apparatus and personal protective equipment. Again, the philosophy given to the hospitals was that you're going to be on your own. The traditional response groups of EMS, fire, and other responders weren't going to be available to you, so you had to serve these functions yourselves. And this was kind of interesting to me that we would tell the hospitals that we're not going to be able to be there as the fire service or as EMS to help support them, when in fact, if we were to look at this situation from a different perspective, let's say the perspective of a large fire event, would we say the same thing to a hospital? Keep this in mind. Perhaps your jurisdiction has a large fire in an industrial complex that takes all your resources and taps the resources of your neighboring departments. Simultaneously, you have a report of a small fire or a fire in your hospital or healthcare facility. Are you going to tell the hospital staff that they've got to fight the fire entirely themselves, or are you going to call additional resources to serve that hospital? My bet is you're going to call additional resources to serve that hospital, and that's the philosophy we ought to be taking with decontamination. We have to apply some critical thinking to this situation and really ask ourselves what hospital staff is in fact going to do decontamination, and furthermore, who's going to do their job, that is the hospital staff's job, when they're out doing decon. And I ask out with some interest, what's the level of retention of the skills needed to do decontamination? That is, regarding personal protective equipment, self-contained breathing apparatus, protective suits, and the like. What's the retention of those skills? What is that retention like among healthcare providers? We know that there's been limited study on the retention of these critical skills and knowledge base among traditional responders. And as of today, as I record this, there is no published data on the retention of this critical skill and knowledge among hospital personnel. We could be setting ourselves up for a problem as we go forward. People that aren't truly prepared, trained, or retaining that training might give us a false sense of security. It might give us some holes in our preparedness. We might expose our employees or healthcare providers to the products of another chemical or biologic event, and the potential for contaminated casualties making their way into an emergency department, into a hospital, could be just devastating or have devastating effects on that hospital's ability to operate appropriately. And let's not forget that we're not just looking at terrorism or intentional acts here. We have to be considered with chemical decontamination at the hospital and at the scene of everyday accidents involving chemicals. So if we were to fast forward to today, we would see that WMD or terrorism training dollars are in fact limited. And the interest in decon, or providing decontamination services at the hospital, is similarly wavering just a little bit. The perception is that the WMD or terrorism threat is gone. All this is occurring while other chemical threats are evolving. Chemical suicide is certainly on the rise. Intentional events involving chemicals continue to threaten us, as do accidental uses or accidental events involving chemicals. So the question has to be asked, hospitals, are you part of public health or part of public safety? Regardless how you answer that question, The public expectation is that hospitals will be available and be able to manage any crisis or disaster situation that comes their way. The public has an expectation that the hospital system will perform, or the healthcare system will perform, just like any other part of public safety in the event of a crisis or disaster. We do have some problems that we need to talk about. The hospitals themselves continue to be under the risk of threat of intentional attacks on these what we would call soft targets. Hospitals are, in fact, a soft target, and we've seen active shooter events at soft targets. The threat of intentional attacks on critical infrastructure continues. That is, public places where we could have mass numbers of people or large numbers of people exposed to a chemical. We also have to consider the naturally occurring environmental and biologic events will continue into the future. Let's look at a couple case studies to finish this point. A St. Louis case involves two men working at a chemical production light industrial facility. They drop a barrel of a material known as nitroaniline, and they self-refer. That means they leave the scene and go to two different hospitals on their own prior to the arrival of first responders, EMS, and the fire department. A total of 8 people self-referred to hospitals from this event, closing 2 hospitals, and this occurred in August 2008. Another situation in Mason City indicates that there was a call for routine trouble breathing at Mercy Medical Center. They found a man in cardiac arrest and noticed a chemical spill after treating the person. 4 of the 5 responders required evaluation after exposure to sodium hydroxide. In Saratoga Springs, Utah, a man was exposed to some type of chemical at work. He drives home and then to a walk-in urgent care clinic, where he exposed 24 other people at that clinic. Some critical points that we have to remember with those case studies and anything involving a chemical event in the future would be that decontamination has to be done on site. Decontamination has to be done before any person, any patient, is put into an ambulance for transport to a hospital or any place else. Contaminated self-referrals may also pose a risk. That is, people leaving the scene prior to the arrival of authority or trained professionals. The fire department must be involved in decontamination operations at the hospitals and decontamination of all victims prior to transport. I cannot overstate this point. We can't put any chemically exposed patients into the back of an ambulance and expect just to move the hazardous material situation then from the scene to the hospital. And I'm going to finish this session with some very unpopular statements. My opinion is that hospitals cannot be left on their own to conduct emergency mass decontamination. Fire departments and other trained professionals need to be involved in that. And if that means you're calling additional resources or pre-staging additional resources at hospitals during a chemical event, then that's what you have to do. Incidents at walk-in or urgent care centers will continue to rise. We have to be prepared for responses to these non-traditional emergency healthcare facilities. Traditional responders must also continually train for mass casualty decontamination. Thank you for joining us here on Mitigation Journal. I appreciate your time today. Again, my name is Rick Rosati, and I'll look forward to talking to you very soon.